started. So welcome everybody to the February ASJ Journal Club. This month it's presented by the Young Aesthetic Plastic Surgeons Committee. And tonight we'll be discussing the article entitled Defining a Safe Corridor of Cervical Branch Preservation in Lateral Platysmoplasty Surgery During Facial Rejuvenation Surgery. So 2 reminders before we begin. Number 1, please mute your microphones. And number 2, if you have a question, please ask it in the chat box anytime. Or as I just mentioned at the end, turn on your camera, ask a question, make a comment, and we would love it. So tonight I'm joined by Dr. Denise Sarhadi, and she'll be presenting poll questions to you throughout the hour. And she'll also relay your questions from the chat box to our speakers at the end of the discussion. So tonight I'll begin by introducing everyone, and then Dr. Saleh will tell us about his article by sharing his screen, and then we'll go to our 2 discussants for their commentary. So our first author tonight is Dr. Daniel Saleh. He is the head of plastic surgery at Newcastle Hospitals, England, which is one of the largest units in the UK. He has a special interest in oncologic reconstruction, and he performs the full spectrum of aesthetic surgery in private practice with a heavy emphasis on facial plastic surgery. He's an instructor at the School of Anatomy and has special interest in surgical anatomy and translational anatomy. He's published widely, including in the Aesthetic Surgery Journal. So thank you, Dr. Saleh, for being with us tonight. Our first discussant will be Dr. Francisco Bravo. Dr. Bravo completed plastic surgery. He's like the international man of mystery. He completed training in Madrid, Barcelona, Paris, London, New York, and Rome. After completing his NYU microfellowship, Dr. Bravo returned to Europe as consultant plastic surgeon at the Erasmus Medical Center in Rotterdam. He later moved to Madrid to become program director at Doce d'Octubre University Hospital and associate professor of surgery at the Complutense University Medical School. He recently shifted his focus to private practice in central Madrid. As a speaker, Dr. Bravo has received the Ralph Millard and Raymond Villain Awards from both the Canadian and American Societies of Aesthetic Plastic Surgery. He's an active member of the Aesthetic Society, and he's the immediate past president of the Spanish Association of Aesthetic Plastic Surgery. He also serves on the editorial board of the Aesthetic Surgery Journal. And thank you, Dr. Bravo, for joining us tonight. And our second discussant is Dr. Graham Southwick. He's in private practice at the Melbourne Institute of Plastic Surgery in Australia. He trained in both ENT and plastic surgery. Since 1979, he's been involved with teaching and research at Monash University and holds appointment as adjunct associate professor in the Department of Surgery. He established both the Advanced Aesthetic Plastic Surgery Fellowship Program, as well as a 3-day annual Advanced Aesthetic Plastic Surgery workshop. He's published widely. He's lectured many times on the Australasian and international speaker circuits. He was awarded the Medal of the Order of Australia by the Queen on the Queen's Birthday Honor List in June 2004 for providing medical assistance to victims of the 2002 bombing in Bali. He was also awarded the 2019 Australian Society of Plastic Surgeons Medal for Outstanding Service to Plastic Surgery in Australia. Dr. Southwick is also the new ASJ Facial Surgery Section Editor. So thank you to Dr. Southwick for also being here tonight. So let's get started. At this point, we'll turn it over to Dr. Saleh to share his screen with us and to discuss his article.
Thanks, Mark, for the introduction. Good to be with you all. I hope that's coming up now, okay, those slides.
It is.
So good early morning from this tiny corner in the northeast of England. I'm delighted to be here chatting with you all. Have a couple of disclosures. I do a bit of consultancy work for a couple of digital companies here in the UK. And the article that my colleagues and I wrote was really looking at particularly the cervical branch of the facial nerve, and something that I guess, or we felt, is occasionally overlooked when we're talking about the deep plane and deep plane access and facial rejuvenation surgery and neck rejuvenation surgery. So first of all, I was quite enthused by the proponents of the deep plane face and neck lift technique, primarily Andrew Giacono. When I first became a consultant about 6 years ago and established my private practice, I liked the idea of seeing the nerves, being aware of where my anatomy was, and then lifting whatever I wanted to lift, knowing where the neural anatomy was. Because really, at the end of the day, the most catastrophic problem that can occur in a rhytidectomy is a permanent facial nerve injury. When you get into the neck and transition over the mandible, it's my kind of feeling that, and certainly with my oncological head and neck hat on, that there's less neural crossover the lower we get down in the face and the neck. And number two, that plane of parotid-mesenteric fascia in the face transitions to the deep cervical fascia in the neck. So the nerves are a little bit more visible and can be a little bit more at risk depending on what your chosen technique is. And then superimposed on that, the UK has become very litigious. I think we're almost as impressively litigious when it comes to cosmetic surgery as the US now. So it is kind of hard to have broad shoulders when you get patients that really their primary aim and motivation sometimes can be to not trust in the fact that complications do happen and that we're there to help them get through those complications. And I was just saying to my co-panelists that more and more patients are doing their research and are actually coming and requesting specific types of facelift. And I think that's superimposed on probably worldwide. It would be fair to say that the majority of face and neck lifters still probably deploy plication techniques rather than entering the deep plane or entertaining entering the deep plane, which we'll get to later. And then about 4 years ago, I had my first case of what I felt was a true pseudoparesis, and I'd probably praxied the cervical branch of the facial nerve. And yeah, I've never really been clinically worried about entering the deep plane, particularly in the neck. So I felt, well, maybe despite I see this anatomy all the time, do I need to try and correlate this to what we teach in aesthetic surgery and what I practice myself? So we looked at some light fixed cadavers that we have in our anatomy lab, and we conducted some dissections of the facial nerve, primarily arising from the skull base origin of the nerve into partially the lower face, but primarily the neck. And we left the nerve, particularly in the transition across the mandible into the neck, on the deep cervical fascia, but relieved it of all its anterior attachments, and also cleared all of the anterior anatomy to expose the sternomastoid, cervical plexus nerves where they may have been, and the subcutaneous fat. And we aspired to do more dissections, but this sort of collided with the beginning of the pandemic and the closure of the anatomy lab and the ability to perform dissections. And we looked primarily at 3 points. We had planned to try correlate all of these points to specific fixed anatomical landmarks or skeletal landmarks, but the most cranial of these landmarks was parallel to the angle of the mandible, drawing a direct line from the anterior border of the sternomastoid. And then we classified the second point as the point where the narrowest distance exists between the anterior border of the sternomastoid and the cervical branch. And then finally, the point at where the nerve enters the platysmal muscle, how far that was from the anterior border of the sternomastoid muscle as well. So in essence, that image just sort of broadly depicts how we went about measuring those points. And overall, essentially the take home from this is that probably at its narrowest point, some of these nerves, when left on the deep cervical fascia, can be as close as 0.5 centimeter to the anterior border of the sternomastoid muscle in the neck. But on balance, the range is somewhere around 1 centimeter. You will probably have, up to that point, you will encounter some of the cervical branch nerves, or in those specific cases where the nerve may have an additional branch as well, particularly more cranially in the neck. Now, as I mentioned, this is a technique that I use all the time, and you'll see here that and I'm sure most of the panelists and others that deploy this method are very comfortable going quite far into the neck to create that deep plane, particularly below the angle of the mandible. And whether that's joined to a SMAS flap cranially in the face or not is up to the surgeon. So what is the relevance of that for me in my practice, or you listeners or other people that may be entertaining taking this procedure on in their practice? And I was thinking about this, and I remember Roland Daniel, I think, coined the term of, have an operation that'll cover 70% of the bases in rhinoplasty. And I think that can be followed through for many aesthetic procedures because of the the risks, because these are operations that patients don't necessarily need. And as I said, plication predominates. So there'll be many people that will probably be reluctant to transition into the deeper plane techniques, which I personally feel yield better results for me. And I see colleagues also get those good results in their hands. And so maybe people that might want to transition into offering at least deep plane treatment of the neck may consider that there may be a safe corridor just anterior to the sternomastoid where those cervical retaining ligaments can be released safely without really encountering, the full brunt of the cervical nerve, provided you're leaving it on the deep fascia of the neck. And that will still release the platysma at its lateral extent at the very least, and give that surgeon the ability to try rejuvenate the neck in that deep plane without potentially encountering the nerve or injuring the nerve, which would be one of their main anxieties. Particularly for those that are less well versed with operating in and around that area. Obviously, this study and any light fixed cadaveric study has limitations. Well, first of all, the neck is dynamic in surgery. By the time you've used some infiltration, if you tumesce the neck for liposuction, if the medial neck is opened and the patient has a platysmal plication medially, that'll change the inherent anatomy at that moment in time. Laterally as well, you'll have assistance through yourself retracting. How's the patient positioned? How does their neck bend and flex? And are they extended on the operating table? And how much of your skin flap have you released? Because that has a bearing on the dynamic movement of the platysma, even in an anesthetized patient that's having a neck lift. The fixity of specimens matters as well. These were not fresh frozen cadavers. So I think one of the potential advantages of that is that the nerve is unless you really encourage it, the nerve is not going to move from where we've left it on the deep cervical fascia. So I think the measurements we got were reasonably accurate, but certainly dissecting a nerve from the parotid tail and from the inferior pole of the parotid could arguably medialize or lateralize the nerve, which would give us some clouded results perhaps. And overall, this is a small sample size. We would love to dissect more and more. And with our clinical hats on and our clinical experiences of operating in this plane, we often see the nerve and where it enters the platysma. But notwithstanding these limitations, we felt as a team that it may encourage others to be a little bit more confident in releasing that platysma laterally to perhaps enter that deep plane and be cognizant that provided they're leaving the deep cervical fascia on the patient rather than on the undersurface of the platysma, they will probably avoid neural injuries or significant neural injuries. Thank you very much.
Thank you, Dr. Sala. That was excellent. Dr. Bravo, feel free to give us your thoughts.
I want to congratulate definitely Dr. Saleh. When I read the paper, I was very happy to see a thorough anatomical study on the cervical branch of the facial nerve, which is really very, very few good papers that have a clinical correlation directly on this nerve branch, actually. It's a very relevant paper. I really want to congratulate him because it's very thorough and very honest, specifically very honest, because he really did mention all the limitations of the study, and that's very commendable. And then I do want to say that the thing that I see most is that it's very applicable, as Dr. Saleh mentioned. I'd like to see his opinion on his techniques for face and neck lift procedures, because I think that it's very applicable to what he just mentioned about the deep plane face and neck lift. Specifically, I think where you're uniting that subplatysmal dissection with that subsmass or deep plane dissection. I think going from the face in a deep plane and being in the neck in the deep plane, putting those together is where you actually can have a lot of issues of injuring that cervical branch of the facial nerve. So definitely that is very relevant for that type of technique. Yeah, definitely.
And did you want to share your screen and show us?
Yeah, so I'm seeing this poll, about FaceLinks. Yeah, I'm going to answer that. Yeah, I do routinely, yeah. And then, yeah. So what I was going to say is that actually, a lot of times, when you're doing neck lift surgery, specifically with combining with face, and again, I do want to hear Dr. Saleh's take on this. A lot of times, that procedure, specifically the deep plane lateral only, like Musto published also, and he was very a big proponent of the lateral only approach for the face and neck lift rejuvenation, and specifically where these techniques like Dr. Saleh mentioned about Dr. Giacono, where he's doing a lot of just lateral approaches, or even Mario Pelle with his LSD technique, where he's not really trying to avoid opening the neck, right? I think that's where these issues come into play, specifically with the patients with a full denture smile, like Dr. Saleh actually mentions in his paper, which is not the most prevalent type of patient, because it's like the Goldie Hawn smile that we all recognize, that type of smile with it. It's you can see them when they come in your office and you say, wow, this is a patient where we can have issues if we're going to do a lot of platysma work. So for that type of patient, yeah, this is definitely a very important, relevant paper, and especially when you're trying to avoid that anterior approach. Now, in my view, is that of course there's a lot of ways of improving the jawline, where you don't need sometimes to undermine or release all of the retaining ligaments of the platysma, and definitely if you're only trying to do a lateral approach and avoiding an open central submental scar, then I would agree that is the best way to go to achieve results in the neck and jawline, going deep and releasing all of those retaining ligaments of the neck anterior to the sternocleidomastoid muscle, like Dr. Saleh proposes, right? But there are isolated neck lifts. There was the anterior only, or the short scar neck lift, where you're not even releasing at all the platysma, and you get quite good results in indicated patients. And then a lot of times, and actually Dr. Saleh mentions this paper and references in his study, the paper by Sami Sino and Charles Thorne, where they actually show different techniques in the neck, where they basically concluded that it's very hard to injure that cervical branch unless you're doing Dr. Saleh's procedure, which was not studied in this paper, actually, where there's a full release of all of the retaining ligaments of the platysma. But in the more common kind of, midline plication, or the sort of Mario Pelle-Ceravo lateral skin platysma displacement technique, or other just removal of strips of the platysma, it's not that easy to injure that nerve. And actually another big issue that we see with another big issue we see with these type of procedures is that oftentimes there is some sort of recurrence or regrowth of the platysma, right? This is a very relevant paper, quite old paper from Ellenbogen from the 80s, where he showed a regrowth of platysma where you're not actually transecting fully the platysma. And that's actually very relevant to Dr. Saleh's point that if you're not fully releasing, if you're not going fully underneath the platysma, you will not have a very good result on your neck, and you will have recurrent bands. And going into that area, actually, of recurrent bands, which is a very big problem in the neck, we all know about that. I did present to you recently, actually, in a recently ASJ GEMS, my technique for caudal platysma denervation, not only to improve platysma bands like Trevidic proposed at the end of 2019. It's a very short study where he was trying to see in just 9 patients, 8 of them with facial palsy, the improvement of over hyperactivity of the contralateral platysma, although he did present one case in the study on a purely facelift patient. But his purpose was to improve platysma bands. My technique, as I commented to you in the ASG James and actually GEMS series a few months ago, that I presented actually in the American Aesthetic Society facial and rhinoplasty meeting in 2 years ago in Vegas, January 2020, and also in Miami last year. My technique really focuses on skin improvement because, you know, we know the platysma is a flat muscle that adheres directly on the skin. And if we think of it, flat muscles that adhere directly on the skin, you can count the platysma, we can count the orbicularis oculi, and you can count the frontalis muscle. And if you paralyze these muscles, you see an incredible improvement on the skin. We know from botulinum toxin injections. So there's a lot of studies on using botulinum toxin for the neck. We know it's very complex because you need very large doses. It's a muscle that's difficult to denervate completely. So again, with these techniques of denervation of that platysma, of the caudal segment of the platysma, you can have improvements in that lower part of the skin, which are quite relevant, even like in this patient 2 years out after the procedure. So again, my take on this is that, of course, it's very important to avoid a denervation of the cranial segment of the platysma, especially when you're doing a full-length, full-depth transection of the platysma, because, again, you want to keep that cranial part of the platysma innervated because, as Dr. Saleh mentions, a lot of times you get cross-innervation with the marginal mandibular branch. And not only that, but the platysma muscle can on itself act as a lateral depressor of the mouth, right, of the lip, right? So when we contract the platysma, we're lowering that lower lip. So we can get weakness of that depressor just by, injuring that cervical branch. So I try to keep that branch healthy or not injured for that cranial segment, and I will fix my cranial segment with lateral suspension sutures and midline plication, but I want my caudal segment denervated, and that's why I transect fully the deep cervical fascia where that nerve lies, as Dr. Satterley beautifully demonstrated in his study. Just a few points for thought, and I would love to hear the input of Dr. Saleh regarding this point about, maybe how much of his techniques is he just relying on the lateral approach only, which will make sense, of course, then to keep that branch intact and do that deep plane dissection of those retaining ligaments, as he mentioned in his study, or does he sometimes consider doing an anterior neck only approach?
Yeah, thanks for those points, Francisco. I increasingly have started approaching the neck medially, centrally and laterally. It depends on the patient's anatomy. If there's significant platysmal bands and they have deep structures in the neck, they've got, they're retrognathic, they have particular anatomy whereby I think it's going to be very difficult to create a submental contour, a cervicomental angle, then I have a very low threshold for opening the neck centrally. And whether that's to do open lipectomy, platysmal plication, modify the submandibular glands, or even just debulk the digastric muscles, I have a low threshold for that because I think it adds quite a bit to the result. If the patient's willing to, take on maybe potentially a little bit of extra risk, a bit of a longer procedure. The difficult patients I find, as you alluded to, that we all still struggle with, are the patients that get recurrent platysmal bands, particularly the patients that preoperatively, in my practice, seem to have complete craniocaudal bands that, even go beyond the sternoclavicular joints. They're almost in the upper chest. And they're patients that don't respond to anything other than, in my experience, a low complete myotomy. And quite often for me to do that effectively, I have to open them medially and laterally as well. I don't do it all from lateral. And there are occasions when, particularly in women, less so men, where I will, just from the medial aspect, do a low transection myotomy, which also helps me contour my plication. So I do a double plication or double-breasted plication in the midline, which I think helps cinch down, if you like, what would be the cranial edge of my two platysmal muscles now towards the hyoid. But then I have seen a few of those migrate back, and inferior to that, they still have a little bit of recurrence, presumably because the lateral innervation low is still intact. So I'm still finding my feet a little bit with that, but I think a low myotomy is really the only solution to really heavy platysmal bands, and no matter how you try to modify the muscle, whether it be lateral or medial, you won't get a lasting result. It may look good for 6-8 months. You can paralyze it with Botox, keep it. And I actually went through a phase of paralyzing the platysma preoperatively to help me manipulate it, particularly for medial plication. But overall, I think it just needs a myotomy. I agree with you.
Well, thank you both for your comments. I think at this time we'll go to Dr. Southwick for his comments on the initial article. But thank you both.
Yes, thank you very much. And thanks very much, Dan Soleil, for a very interesting paper, and I think one that stimulated a lot of discussion. From a face point of view, I think a comment on the paper, which I think we've already talked about, is we're dealing with fixed cadavers here, and measurements are in millimeters. And I think with neck movements, and I know you've addressed that, Dan, but I think that even with flexion extension on your patient on the operating table, it's still, this paper gives us an idea of where those branches go. Interestingly, as we've heard already from Francisco, that basically there are a lot of papers out there that have looked at fresh frozen cadavers and the cervical branch, and I'm referring to the same papers that Francisco said, but things like Sammy Sino's and Charles Thorne's paper, which did talk about the fact that the cervical branch doesn't really enter the deep surface of the platysma muscle until you get up towards the facial vessels. So, you know, you've got a fair degree of freedom in that region. And I think if you preserve the deep fascia, and I often open the neck, it's pretty normal for my facets, then if you keep the deep fascia intact, your nerve's going to be underneath that. It does branch through, and I think as long as you're very careful and watch it, you're pretty safe. But I think for those novices and those starting out, yes, it's a very nice thing to release those cutaneous ligaments. I think you need to release the attachments between the sternomastoid and the platysma. But just a little comment, when you're dissecting the platysma in the deep surface, if you see the muscle fibers there, you know damn well that the nerve's going to be deeper to that until you get towards the midline and towards the fascial vessels. A little word about the pseudomarginal mandibular palsy, which Ella Bogan and Owsley are really the two people who published in the PRS in '79 and around 2003, talking about the pseudo marginal mandibular palsy. We're all used to handling nerves in our training, and we know, for example, in the wrist, you know, the Martin Gruber change, or where the median nerve goes to the ulnar, or the opposite of that, which is Martinacci's anastomosis, where nerves do communicate with each other. And the facial nerve is no exception. We know about the pes anserina, we've all studied that, and we know that there's no doubt that sometimes the marginal branch will have branches coming to it from the cervical branch and vice versa. So I think it's important to be careful with the upper portion, particularly in the upper 5 centimeters. And if you look at some of the papers that are out there where they've studied where that nerve goes, is it a single nerve, is it multiple nerves? And we know the lowest part of it goes towards the thyroid. One little question about that is, where do you divide the platysma? What level? I've always tried to do it fairly low, where the platysma muscle fibers are becoming thinner, rather than producing a band if you make that division across a myotomy too high. And I like to do it through platysma only, preserving fascia on the deep surface. It worries me a little bit, and I'd welcome Dan's comments in regard to what does he do, for example, in the secondary facelift, where you're dissecting and looking at that area and going into the platysma. Do you go looking for that nerve? Does the 1 centimeter still play a role or not? I think when you look at the platysmal bands, we're looking at a totally different area. There's no doubt that the work that Francisco already mentioned, which is Trebedik's technique, that he looked at facial nerve palsy, and he found in those patients they didn't have platysmal bands on the side of the facial nerve palsy. However, Dan Baker disagrees with this, and he's also demonstrated in some of his papers that bands still do exist even if you have a palsy situation. So there's a lot of debate as to what causes that. Is it retraction of the muscle fibers when you divide them? But Botox is only a temporary relief. I often use Botox after my facelift or the end of my procedure, just to minimize let the fibers lengthen a little bit during the adhesive process and the healing process. So I'm not sure how you get rid of platysmal bands altogether. Perhaps one of the things I will comment about is the nice procedure that Mario Caravello talked about, where he does his lateral skin platysma displacement, even with an open neck. I've used that. That, I think, is interesting, because those that understand it, you're dividing the platysma about 5 centimeters from the mandibular line, and you're dividing it transversely as well as vertical. And that's creating a flap, composite flap really of skin, soft tissue and platysma, but you're changing the direction of platysma fibers. So as you pull that laterally, you're actually creating a more transverse fiber orientation of the platysma muscle. Maybe that's why he feels the bands are better. And if you look at his papers, he reports on his original techniques of doing the standard low division of the platysma, about a 46% recurrence of bands. Whereas if you do it with his technique of the lateral skin platysma displacement, he says he's reduced that down to 6%. So that's a huge drop. So maybe that is one little key point in relation to the platysmal bands. I think there's one would expect there are communications. I'm not sure about the pseudo-marginal mandibular palsy. I think that's really just an intercommunication between the cervical branch and the mandibular branch. As long as you preserve that at its beginning, particularly in those that are in the more cephalic position, and keep those branches intact, then you're unlikely to see that syndrome, if it, in fact, it really does exist. I have not seen it in all my cases of facelift so far. So I think a very good paper. I think it's wonderful to dissect out nerves, to preserve them where you can, to be aware of the anatomy. As we know, as we progress over years, we're finding that we are getting more and more detail on the anatomy, which is wonderful because it helps us all get better results. Does it solve platysma bands? No. Should you divide the platysma totally or partially? I'm interested in Dan's comment on that in regard to his paper, and also what would he do with the secondary facelift patient. So thank you for allowing me to discuss the paper.
Thank you, Dr. Selpik. So yeah, Dr. Sella, if you don't mind responding to those questions, that'd be great.
Yeah, so the secondary neck lifts, which in all, if the majority, I'm thinking it's very rare I do an isolated secondary neck lift. It'll be a face out, or at least a lower face and neck lift. So those patients that, particularly I don't have an operative record, and for me, they're patients that have had their first facelift 15, 20 years ago by somebody I'm familiar with, and they probably did a lateral smazectomy or platysmectomy type procedure. I just, first of all, just find when I'm in the neck and I'm on top of the sternomastoid, I try to find the great auricular nerve, just because I want to preserve it and I don't want to injure it, provided they have sensibility in their ear lobule preoperatively. And then I actually hydrodissect with just some injected saline on the surface of the sternomastoid and contiguously lift what that scar and sternomastoid fascia will be medially into the platysma, on the premise that probably the platysma, if it's been manipulated or moved before, the scar will have weakened it. It won't handle my sutures that I want to do my lateral platysmoplasty and take it up to the mastoid fascia. So that's sort of number one. But the reason I start actually on the surface of my sternomastoid rather than in a fresh, specimen where you can see the platysma quite clearly where its junction is at the anterior border of the sternomastoid is my first starting point. And then, provided I see the pink fibers of platysma, which you kind of alluded to, if I see a white deep surface of the platysma, I kind of get a little bit anxious that I could be lifting the deep cervical fascia with my platysmal flap. Now, of course, it could be scar in a secondary case, but I just like to play a flat bat. So unless I see pristine pink, I'm a bit anxious, and I know that I could be lifting up the cervical branch with the nerve. And as I go more medially and slightly more cranially, even a low-lying marginal branch, particularly when I get close to the facial vessels. So I'm pretty cautious actually in secondary cases, because any traction on those nerves or any traction at all, it just gives me a little bit of anxiety. Now, if I'm struggling to get in a good plane and it's just heavily scarred, then I just limit my dissection in the deep plane laterally to just anterior to the sternomastoid enough that I think I can mobilize the muscle to some degree to effect a change. And then more often than not, I'll be going centrally into the neck as well to modify the platysma medially, which is typically a partial myotomy that's low, like I described to Francisco, to allow me to do a fairly significant plication where the caudal edge of that in effect will sit at probably about the level of the hyoid to try get the cervicomental angle back. And I don't tend to join my subsmass flap with the platysmal flap in secondaries either. And in certain primary cases, I've stopped doing that as well. So I sort of take a centimeter sort of circle around the angle of the mandible, knowing that that's a danger zone and that transition can be a little bit tricky. And in those secondary cases, particularly where I don't know what's happened before, they may have just had a simple plication procedure in fairness, but I'm a little bit more cautious, and I tend to lift two separate flaps rather than have a contiguous flap for that reason. You also mentioned about Owsley's report and the first sort of notion of pseudoparesis, and I think you again alluded to something important, that there's a significant body of practitioners that probably think that pseudoparesis may be a misnomer, may not be a sort of build the right way, and that it may well, just exactly as you say, whilst we know that in a lot of, for example, with my neck dissection or parotidectomy hat on, a lot of patients get a marginal palsy that recovers in the weeks to come after the surgery. And the reason they get a marginal palsy is because that nerve has very little interconnection, if at all, with the buccal nerves above it. So vis-a-vis the same for the cervical branch, that we know and we see even over the deep fascia over the submandibular gland, there are connections between the cervical branch and the marginal mandibular. So provided you stay low with your myotomies and those techniques, you will preserve that cranial neural load, if you like, to avoid, I think, any consequence of neuropraxia. And I've had one meaningful one where the patient had a clear problem with the depressor, but when they rolled their lip out with mentalis, it was absolutely no problem at all, which was relieving for me because I knew I'd stayed low. Happy Halloween. I know you Americans love Halloween, don't you? I was once in New Orleans for Halloween. I thought I was in a different planet. It was a completely different experience.
This is really nice.
That you're doing, Mark?
No, I had nothing to do. I can hardly take this seriously anymore. But I had another question. Well, I mean, thank you for that. I mean, they're great responses. For Dr. Bravo, I know that I think that you've done the Mario procedure in the past, and you're not doing that anymore. And I'm curious about your transection of the nerves. I mean, at this point, do you feel like you've figured out the phenomenon of recurrent bands? And are there any downsides to doing your procedure? I think you might be muted.
I did stop doing Mario's procedure, and actually Mario stopped doing Mario's procedure. you know that Mario is now doing what he calls platysmectomy in order, and Dr. Saulik also knows very well, because again, I think the problem with platysma bands are really dynamic, hard platysma bands that really Mario really wants to or counts that. I think again, it's just like the problem of recurrent platysma bands, which is a problem, really depends on what you defined as recurrent platysma bands, right? So if you defined a person that after a neck lift is able to do this as having a recurrent platysma band, then I don't think you're going to have 80% of recurrent platysma bands, because I think that you don't want to completely have a patient not being able to move at all his platysma in the full cranial and caudal part, right? So, and again, having a little bit of skin redundancy here, which is, I think, one of the most difficult issues in neck lifting. Patients with thin skin, that thin skin comes up here around the hyoid, this area is very mobile. You do application, that application cheese wires because the platysma is very thin. And then you get a little kind of issues here. And of course, if you're really looking into that, then of course that in older patients with thin skin, you're going to have a lot of platysma bands when it's really, skin laxity in that area, I believe. And of course, I would like to hear also, what Dr. Saleh and Dr. Saud would think about these recurrent platysma bands problems. But I really think that, and Dr. Saleh mentioned it before, the platysma has an issue in that lateral portion. So if you're really coming very lateral, with that sort of trying to put together your deep plane on the face with your deep plane on the neck, and you come right through that part in the tail of the parotid gland, and you transect, if you're not careful and you go too deep on your deep cervical fascia, which you shouldn't, and as Dr. Southwick mentioned, if you stay above that deep cervical fascia, you shouldn't have any issues with those nerves. But again, I think that this area that Dr. Saleh mentioned is really a very dangerous area right when that nerve exits the tail of the parotid gland, because then it's really in very close proximity with the cervical, with the marginal mandibular branch, right? And that is a more of a serious problem, I believe, having a permanent injury to the marginal mandibular, right? So again, when I'm doing my technique, I'm keeping together the platysma attached to the skin for only the most caudal part of my neck dissection below the hyoid. And actually, the first one to propose that was actually Skoog. Skoog was the first one to really see an advantage of keeping that platysma attached to the skin, and also the orbicularis attached to the skin here, because he would pull on both sides deeply. And then the only missing link he had was this mass, which he didn't actually use until, Mitz and Perroni discovered it. So he actually said, okay, now I have the missing link in between my platysma and my orbicularis, which is this mass. And he was the first one to actually clinically use this mass with this dissection. But actually, yeah, Raul Gonzalez and Mario Pelle popularized recently that leaving that skin attached to the muscle. But again, I only see it useful for that caudal part. I don't want to elevate that platysma in that danger zone here. So that cranial platysma, I will really tighten it medially, and then I will use suspension sutures just for that cranial part. And once I've reduced the platysmal tissues, I will use suspension sutures, type of Jampapa type sutures, but only after reducing the volume underneath the platysma, because I really believe they will not work if you have a large volume underneath that platysma. They will just, you will have a recurrence of those issues underneath the jawline long term. They will not hold long term, those suspension sutures. But I'm really excited to hear Dr. Southwick and Dr. Saleh about this.
Dr. Southwick, what are your thoughts as you hear this?
Yeah, well, there's some very interesting comments. I agree with Francisco. I think it is very important not to undermine too much of the skin laterally and low down below the hyoid, because you can produce considerable irregularities there. I do use the Corset platysmoplasty significantly in patients. I'm not scared to open the neck. I find it gives a much nicer result long term. Of course, everyone worries about the patient, because the patient may have dynamic bands or static bands, as Francisco was referring to. It's really the static bands where you have trouble. I also think it relates a little bit to the origin of the platysma, because I've dissected a number of fresh cadavers, and I know my colleague Brian Mendelsohn has too. And when we look at the attachment, we talked about Finas's ligaments as the mandibular ligament being a solitary point. It's actually not. It can actually be quite a broad origin of the platysma coming from the mandibular line. So it can be quite wide rather than just a narrow point. And that ligament can, I think, have a play on platysma bands. The broader it is, of course, you're more likely to have multiple bands. If it's narrow and you divide that, then probably you're not going to have too much in the way of bands. But I don't have any statistical study, or I haven't really studied that enough to be sure about that, but it's just a feeling I have. I think with the corset, you have to be careful. You're moving a lot of your tissues medially. You need to undermine your skin widely to gain a good result. One technique that I have learned over the years is what I call a platysmopexy. And what I'm doing there is I'm actually doing small plications of platysma a centimetre or two below the mandibular line. When you've got your platysma in place and the corset done, you've pulled it laterally. I don't like the GM puppet type sutures because I have had a few patients that complain of a very tight neck when they move their head, and it lasts for several months. So I've really gone away from doing those suspension sutures, but I do certainly suture to the parotomasseteric fascia and also to the sternomastoid fascia laterally. But the platysmopexy, just taking small bites of the platysma and plicating them, really can define your jawline. And I think it does have an effect on the platysmal bands. It does seem to create a nice hollowing under the neck area. And really, if you want that patient, particularly in the more fatty neck, where you're trying to create better demarcation of lines, it does give a nice result. It's a little technical tip that I find very useful. I use it for a vicral suture for that. And it does give quite nice results. I think the whole concept of platysmal bands is still a little bit of a dilemma for us as facelift surgeons. I do think Botox does have a role. I don't think, obviously, the palsied patient that we've talked about can still have bands. And you don't want to get rid of the dynamic status that Francisco talked about. I think that's really important to keep facial expression, to make sure that the perioral area has the ability to pull down and express yourself. And I believe that we're still away from being able to get the perfect result. The fact that there's still several techniques out there to try and fix the neck shows me that we really haven't hit the button properly yet.
Dr. Southwick, what about that little bit of redundant skin that Dr. Bravo brought up? Any way to prevent that or treat it?
Look, I think it is a difficult situation. It depends a lot. One of the big points there is do not defat that area too much, particularly pre-platysmal fat. Subplatysmal fat, getting to the digastrics, I don't have a problem with that. But I'm really nervous about taking too much fat in that area because that's leaving yourself wide open for that problem you described. So leave the fat. If fat's your friend in that area.
Thank you so much. So why don't we turn it over to Dr. Denise Sarhadi at this point?
Thank you so much. This has been an amazing discussion. I'm definitely going to go back on YouTube and watch it. And I encourage everyone to also go back on YouTube and watch this again and write notes. So thank you everyone for participating in the polls. I'll just briefly go over them. And then my queen, Dr. Mioto, has a question for the discussants. So about a quarter of our audience does not do deep lateral neck dissection. So for those people, I hope this has been enlightening, but they don't do it. The other, about half of our audience does do deep neck. And of those half, only half routinely release the cervical retaining ligaments. And of those people who do not release the cervical retaining ligaments, 40% of them feel like they don't need it for their result, and the other 40% feel as though there's a risk of nerve injury. So I hope this article has given some confidence or clarity on that issue, along with the discussion. And then in terms of neuropraxia, the majority of our audience actually reports a rate of neuropraxia that's consistent with the literature or lower, so about 1.7% or lower. And I think that's something that probably all of us also experience, either there or a bit lower. And then I'd like to turn it over to Dr. Mioto. She has a question for our discussants and our author.
I think you may be muted.
Oh, I think I can't. Is your microphone off?
Hello?
There she is.
That's better.
Hey, can you hear me?
Yes.
Okay. Let me go back again. Thank you for this. This has been wonderful. My question is, since we are always discussing about recurring platysma bands, the hardest things to fix, and myectomies and things like that, have you ever had any permanent cervical branch injury? And if not, you think that that's because the platysma innervation and connections is so strong, or the muscle is so strong that it comes back regardless, because even sometimes after removing all the muscle or part of the muscle, it comes back. So I just want to hear your thoughts on injury of the cervical branch.
Sure, I'll go ahead, Dr. Mioto. I've not seen a permanent nerve injury in my aesthetic practice to the cervical branch. I think it probably is a very robust nerve, although I take great care to leave it where it should be. Like Graham discussed, there's probably enough crossover that if you did permanently injure it, it may not manifest itself clinically, or it may manifest itself clinically with a beautiful result because you paralyze the muscle and it's not banding anymore. And as superimposed on that, the only patients I genuinely see very little platysmal movement in that may have had pre-existing bands are neck dissection patients where they have a transcutaneous and muscular incision across the neck that spans the whole neck beyond the borders of the sternomastoid. And it's not, like we've said, it's not exclusive to those patients, but they're the patients that have the most profound paralysis that I see in that muscle, which is why I do low myotomies for patients that I just find very difficult to improve their result. And I tell them, I can't necessarily eradicate your bands, but this will go some way to improving them, I hope, to the point where you'll be satisfied. And that in combination with other things that we've had a discussion about, a variety of sutures and so on, may help. And much like Graham, I'm a big fan of the sort of what Feldman called the go anywhere sutures, which are paramedian and lateral in the submental area along the platysma. But thankfully, no permanent nerve injuries.
Can I make a comment, if that's okay, Mark? Hello?
Please, thank you.
Yeah, I was just going to make a comment here. Yes, cervical division of the cervical branch on a permanent basis has been carried out for a long time with brachial plexus reconstructions. I remember years ago we've done that, and I know there was a paper by, I think his name's Sarkowski or someone like that, and it's in the radiological anatomy literature. But he looked at fixed cadaver heads, and he found that in most branches, most cervical branches dissected, most of them had single branches only going to the platysma. Occasionally they'd see in his 5 cadavers, he had, I think, one that had 2 branches going to the platysma, most were single. And I know the same was found with Sino and Charles Thorne's paper, where they looked at 8 fresh cadavers, and they found that they had a single branch only. And that nerve has been divided to use for brachial plexus reconstruction to re-innovate. And it's about the size of a little bit smaller than the medial pectoral nerve, for example. So in those cases, I don't think they've been studied in a big way, but I don't think it's really made a huge difference to the neck area, and the bands I have no comment about, but that would be interesting to look at it, because there are patients out there with brachial plexus reconstructions where the cervical branch has been used as a motor branch.
And just a follow-up. Yeah, thank you so much. Just a follow-up question on that. So, for example, for the patients that have the full dental smile and there is the pseudo marginal branch injury that the lower lip paralysis, but the mentalis is working, and while that's the cervical branch, is not really the marginal mandibular branch, and sometimes you see that weakness with this full smile, it's probably gonna be fine then, because it's just that kind of pull, usually is a pull and not really a full transection. And with all the connections, I just think that's important to keep in mind, because that sometimes it's a little bit scary. And I had a case like that. I was just, wow, that's not the mandibular branch because my mentalis is functioning, and then the connections come back. But just want to keep that thought in.
I think it's very important to preserve your cranial branch of your cervical, the multiple branches coming out from that junction between the marginal branch or mandibular branch and your cervical branch. Preserve those, because there will be communication circuits in there for sure, and they'll be the ones that cause that issue for you. But almost always, like you've talked about, they almost always recover. But they're certainly a grey hair problem for those that are watching them for the first 6 to 10 weeks. And I've had a few of those over my career, but they've all recovered. I've never had a permanent one, as long as you preserve that cranial one. And if you look at, again, if you look at Sino and Charles Thorne's paper, they describe where that nerve is. And it's the same with Chowdhury's paper, that, he talked about exactly the anatomical location below the gonian. It's within a centimetre of that area. So be very careful in that region to maintain those communicating branches. But I believe most of those would recover.
Yeah, and have Botox for the contralateral side until you recover.
Yeah, absolutely.
Yeah, absolutely.
Thank you, Dr. Miotto, for your question. Does anybody else have any questions or comments?
I've got a question actually for Francisco and Graham. I'm increasingly drifting towards, and I don't have any long-term results yet, but the early results are optimistic of not joining my deep plane, like I mentioned, between my facial flap and my neck flap laterally. Do you guys do something similar, or do you use a contiguous flap still? And I actually mark out the gonial angle and I avoid it completely, basically. I skirt around the whole thing. So I stay above it, I stay below it, and I leave all of that parotid fascia and that superficial fascia and the SMAS completely adherent to the parotid tail in that area. The only problem I've had with that is when I've affected my lift, you get a bulge. If it's a dynamic parotid gland, you get a bulge. So I just use a PDS to flatten it down. And so far that seemed to be acceptable. But I wonder if you guys could guide me on that or have any comments on that. That's something I've just been playing with for the last year or so.
Well, I don't. I'll go and I will let Dr. Southwick and because he probably, well, he does have the most experience of anyone here. So, but definitely, I do avoid that area as well. I do avoid it. So I will, you know, I will. That's the only area that I leave not undermined underneath the platysma. So all my cranial segment of the platysma, that will go subplatysmal from the anterior approach, but I will go all the way laterally, but then I'm underneath the capsule of the submandibular gland, so I'm dissecting quite low underneath the platysma and the cranial segment. I will go almost to the jawline, but I'm very deep there, and then of course I'm going superficially also. So that's a double. I'm going above and below the platysma, above the hyoid, and below I'm only going deep to the platysma, but I'm transecting here. So then I leave that area without releasing from the lateral side, from the lateral approach. And if I need more tightness there because I don't have enough from my medial plication, I will use, you know, similar sutures as you mentioned, both of you, but in more like a cable fashion, putting it into the mastoid. So I will tighten a little bit that cranial segment if it needs more tightening. But yeah, I think that's an area where, as you very well mentioned and you described in your paper, that's the area, and Dr. Southwick just mentioned, where you have a lot of connections between the marginal mandibular, the cervical branch. I do not want to go there. I know that there's some authors that like to put those two dissections together, like, you know, Andrew Giacono does that. And I guess that if you are well above that deep cervical fascia, you shouldn't run into problems. But again, I do agree with Dr. Miotto as well. It's that those weakness of that depressor postoperatively is, although you can use Botox and I haven't had either a permanent injury of those weakness of the depressors, but yeah, you know, I don't think it gives you that much advantage in your result overall, putting those two dissections together. I'm interested to see what Dr. Southwick says, though.
Yeah, I actually agree with you, Francisco. I think I like to look. I find the facial nerve is my friend. I'm used to doing microsurgery on it. I know the nerve well. I don't have a problem dissecting it, as long as you preserve those tiny branches under magnification. So, but as a general rule, there's a couple of points here. One is, you know, you dissect one side and you try to preserve it as much as you can. I don't mind continuity. I'm happy to do that if the dissection plane is easy. But you know, on some patients it is not easy, and particularly secondary patients, it's not easy. And especially if you don't know the history of what was done previously, even if you try to find out. So I'm never concerned about leaving it. What I am concerned about is some of the early flaps that were talked about with platysma and so on, because I like the hollow between the mastoid and the gonian. I like it to be a nice hollow in there. And I think sometimes you've got to do a continuity of dissection to achieve that. But I like to look at the parotid masseteric fascia. I'm not scared to go under the SMAS and look at the nerves and dissect them if need be. I'm always aware, and this is a point for the novice, if you haven't done many facelifts, I've seen a number of papers now, and I've done dissections myself on the cadavers, fresh frozens, where you think the facial, you do one side, you think, oh, I can see the nerve easily. I know where it is. It'll be the same on the other side. Big mistake. It's not. You often go onto the other side and you find the anatomy is totally different. So be aware of that. And that's probably, therefore, for Dan, what he's doing is probably a very safe way to go. Preserve it if need be. You don't have to bring the upper SMAS and the lower platysmal flaps. You don't have to necessarily undermine them in one go. I don't think that's a problem. As long as the tissues move in the direction you want, and as long as you maintain the nice contouring, particularly behind the mandibular ramus. So I don't have a fixed idea on it, is what I'm saying.
And then if there's too much volume, you can do like you already published also in I think it was a Viewpoint article, right? You can remove the parotid altogether, right? For in a facelift patient, right? that I've also do.
That's very common in this country where people drink a lot of beer. They get the large parotids, the men. And I'm not scared to take a superficial parotidectomy. I don't have a problem at all. I get nice results. In fact, another interesting little comment on an aside is I had a lady from Houston came out for a facelift. She'd had a parotid done, and she had Frey syndrome, gustatory sweating, on one side where the parotid had been removed. And I did a SMASectomy on the contralateral side and used the SMAS on the other side, the SMAS from the contralateral side as a graft over the top of the parotid, cured her gustatory sweating at the time of a facelift. So there's all kinds of ingenuity things you can do with faces. And don't be concerned to do different things on each side, because you will find the anatomy is different. Study your patient well before the surgery is the important thing. All those decisions are not made on the operating table.
Thank you. Again, any other questions or comments for anybody? So if not, I want to thank Dr. Sala, Dr. Bravo, and Dr. Southwick for really a fantastic session. I wish we could go on for another 2 hours. I really do. So thank you very, very much. Thank you to Phaedra and Laura Simpson for making tonight such a success. And we will hopefully see you all back here in March for our next journal club. It'll be hosted by Ryan Austin and the ASJ Next Generation editors. To the audience, thank you for joining us, and have a great night, everyone.
Thank you very
everyone.
much.
Thank you. Good night. Thank you.
Thanks, guys. Take it easy.
Great. It was wonderful. Thank you.